Hello everyone, welcome to our channel. Today we are going to discuss about a very important topic, which is approach to anemia. Anemia is basically defined as hemoglobin level or RBC count below the normal limit. Say for example, hemoglobin normal level is 13 to 17 gram per deciliter in adult male, and 11.5 to 15 or 16 gram per deciliter in female. If hemoglobin level falls below the normal limit of the hemoglobin, like less than 13 gram per deciliter in male and less than 11.5 gram per deciliter in female, then this condition is known as anemia, or anemia can be defined as decreased RBC count below the normal limit. So there are certain signs and symptoms of anemia like weakness, fatigue, pallor, and there are so many other signs according to the type of anemia. Breathlessness, palpitation in case of severe anemia. So whenever a patient presents with these signs and symptoms classical of an anemia, then we ask for a certain investigation like hemoglobin estimation and hematocrit estimation. In case of anemia, hemoglobin and hematocrit is decreased below the normal limit, and we identify the anemia. Once the diagnosis made that person has anemia, then we need to classify which kind of anemia is this to provide a precise treatment and better recovery. Then we order a reticulocyte count. If reticulocyte count is normal or low, normal reticulocyte count in adult is less than 2% of total RBC, or 0.5 to 2% of total RBC. Whenever the retic count is normal or low, then we ask for the mean corpuscular volume, MCV. Normal MCV is 80 to 100 femtoliter in an adult. When MCV is less than 80 femtoliter, this condition is known as microcytic hypochromic anemia. When MCV is 100 to 80 to 100 femtoliter, then this is known as normocytic normochromic anemia. When MCV is more than 100, then this condition is known as macrocytic anemia. On the other hand, if the retic count is high, then this indicate the increased process of blood synthesis, particularly RBC synthesis or erythropoiesis increased due to certain reason. And along with this increased retic count, we ask for certain tests like serum bilirubin, LDH, and haptoglobin. If serum bilirubin is increased or LDH is increased and haptoglobin decreased, this indicate a condition of hemolytic anemia. And if these are not in support or not, bilirubin is not increased, LDH is also not increased, and haptoglobin is increased, then this anemia is due to the blood loss. In all these conditions, blood loss and hemolytic anemia, retic count is increased, but only hemolysis, bilirubin increase, LDH increase, and haptoglobin decrease. Now we will discuss about the microcytic hypochromic anemia. As we have discussed, whenever the MCV is less than 80 femtoliter, then we ask for serum ferritin test. If serum ferritin is decreased, serum ferritin is a stored form of serum iron. If this decrease, then this is indicative of iron deficiency, anemia. If the serum ferritin is normal, then we ask for a HB electrophoresis or HPLC test. If the HPLC test is normal, then we ask for bone marrow iron test. If the iron stored are high, then this is the condition of anemia of chronic disease. If the bone marrow iron stores indicates ringed sideroblast, this will be an indicative of sideroblastic anemia. If the HB electrophoresis is abnormal, showing increase HbA2 or HbF, normal HbA2 level is less than 3.5% in HB electrophoresis. If it is more than 3.5%, or more accurately we say, if it is more than 4%, then this might be an indicative of beta thalassemia, alpha or beta thalassemia. In case of thalassemia, we ask for the parental screening and molecular test for the confirmation of the diagnosis. Now the other category is macrocytic anemia, in which MCB is more than 100 femtoliter. There are certain clinical clues or history, like macrocytic anemia associated with alcoholism, liver disease, hypothyroidism, cytotoxic drugs, and previous abdominal surgery. In small intestinal surgeries, there may be a result in macrocytic condition. After looking for this history and clinical clue, we advise reticulocyte count. If reticulocyte count is high, then this is indicative of certain blood loss or hemolytic condition. In case of high retic count, we ask for a peripheral smear examination. If we find polychromasia, nucleated RBC, and increased retic count, then this is indicative of hemolytic anemia or blood loss. If retic count is normal or below the normal limit, then we ask for peripheral smear. If we seen macroveilocyte, hypersegmented neutrophils, Cabot ring, these are indicative of megaloblastic anemia. And then we ask for the serum folate level and serum vitamin B12 level. If both of them or any one of them is decreased, then this is confirmatory of the megaloblastic anemia. If peripheral smear shows oval macrocytes, then this can be seen in liver disease, hypothyroidism, and alcoholism, that we can easily correlate with the clinical history. If the peripheral smear shows round macrocytes and deshematopoiesis, then we should evaluate the person for the myelodysplastic syndrome. Now the last category in normocytic normochromic anemia, in which MCB is between 80 to 100 femtoliter. The size of the cell is normal. We ask for retic count. If retic count is high, then this is indicative of hemolytic condition. If retic count is normal or low, then we take the history of underlying chronic disease or renal failure. If the history of chronic disease or renal failure is present, then we evaluate the person for the anemia of chronic disease or the chronic renal failure. In the absence of history, we go for the bone marrow examination. If the bone marrow examination is abnormal, then aplastic anemia and ineffective erythropoiesis might be a case for the normocytic anemia. If the bone marrow examination is absolutely normal, then we should evaluate the patient for the anemia of chronic disease and chronic renal failure. In chronic renal failure, kidney start decrease production of the erythropoietin, or we can say the decreased production of erythropoietin from the kidney, and this will result into the decreased erythropoiesis. And in the condition of chronic disease, there is elevated level of interleukin 6. They inhibit the they promote the hepcidin, and hepcidin ultimately inhibit the level of or transport of ferritin and result into the anemia of chronic disease. Now we will see the diagnosis of hemolytic anemia, as hemolytic anemia is a very broad category of anemias, so they need a separate description. So first is the clinical findings. What are the clinical findings associated or indicative of hemolytic anemia? Pallor, jaundice, history of gallstone or splenomegaly, leg ulcers, dark colored urine, red, dark and high colored urine, dark colored stool, and red, dark or high colored urine. So these are the clinical findings may be indicative of hemolytic anemia. What are the laboratory findings associated with the hemolytic anemia? In the urine, we have increased urobilinogen, hemoglobinuria and hemosideриnuria. And in peripheral smear, increased polychromasia or number of nucleated RBCs. Reticulocyte count is increased. Reticulocyte is a immature RBC. Bone marrow shows erythroid hyperplasia. Stool examination shows increased stercobilinogen level. Serum unconjugated bilirubin and serum LDH are increased because of hemolysis. Hemolysis will increase the synthesis of bilirubin. Now the morphological diagnosis of hemolytic anemia. Morphological diagnosis of hemolytic anemia. Reticulocyte count is increased. Then we ask for the peripheral smear examination. There are so many types of cell we found on the peripheral smear, and they help us to make a diagnosis of a particular type of hemolytic anemia. Like target cells along with the nucleated RBC is indicative of thalassemia. In the target cells, we have a target like RBC in which there is no central pallor. There is a target like cell in which no central pallor seen. A pallor is surrounded the pericentral area. An increased nucleated RBC indicative of thalassemia. If the peripheral smear shows sickle like cell, this might be indicative of sickle cell anemia. If the peripheral smear shows microspherocyte without the central pallor, this is seen in the hereditary spherocytosis. If the peripheral smear shows elliptocyte, this might be indicative of hereditary elliptocytosis. If the peripheral smear shows cystocytes or broken RBCs, this might be associated with the microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia seen in TTP, hemolytic uremic syndrome, and the prosthetic cardiac valves. If the spherocytes round RBCs without central pallor seen, then we ask for the Coombs test. If the Coombs test is positive, then this is because of the autoimmune hemolytic anemia. If the Coombs test is negative, then we look for the hinge bodies and white cell. If hinge body and white cells are present, then this is indicative of G6PD deficiency. So this is a brief about the diagnostic approach or diagnosis of hemolytic anemia, in which we have discussed about the various clinical findings, various laboratory findings, and the morphologic diagnosis of hemolytic anemia on the peripheral examination. Thank you. Hello everyone. In this video we will discuss iron deficiency anemia. Iron deficiency is the most common nutritional disorder globally. This is characterized by inadequate hemoglobin synthesis due to lack of iron. Hemoglobin is a blood pigment composed of heme and globin. Heme is composed of iron and porphyrin ring. So whenever there is deficiency of iron, this will result into the decrease or inadequate hemoglobin synthesis. There are certain high risk individual or high risk groups in which there is high chances of development of iron deficiency in anemia. First is toddler or children, due to low iron in the milk and high growth demands in this age group. Second group is adolescent girl and women of the childbearing age due to blood loss in menses and pregnancy. Elderly individual, often due to occult GI bleeding or poor dentition or diet. So these are the three high risk group for the development of iron deficiency anemia. Now we will see iron distribution and metabolism. Body iron is strictly regulated because free iron is toxic, and it is divided into two main compartments. 80% of body iron is present as functional iron in the form of hemoglobin, myoglobin, and enzymes such as catalase, cytochromes, and 15 to 20% of iron is present in the form of store iron like ferritin and hemocitrin. Ferritin is a soluble store form of iron present in liver macrophages, and this is the primary source of iron store. Hemocitrin is insoluble, normally seen in iron overload, and this can be visualized with the help of Prussian blue stain. Now we will see the metabolism and absorption of iron. Iron is predominantly absorbed in proximal duodenum, and the absorbable form of iron is ferrous. This ferric form is converted into ferrous with the help of duodenal cytochrome B. So dietary iron is present in mainly two forms: heme iron and non-heme iron. Heme iron primary source is animal products, animal food products, and non-heme iron is predominantly present in plant-based source. Heme iron is very efficiently absorbed with the help of HCP1 or heme carrier protein 1 in the enterocyte of duodenum. Non-heme iron is poorly absorbed, and this absorbed with the help of DMT1, divalent metal transporter 1, in the duodenal enterocyte. Once the iron reaches into the enterocyte, here the iron is transported from enterocyte to the circulation with the help of ferroportin. In the circulation there is a protein named as transferrin, which acts as a carrier protein for iron transport in the plasma or in bloodstream. This transferrin transport iron to the various sites like bone marrow for erythropoiesis, and some of the iron to the liver in the form of store form in ferritin or hemosiderin. Whenever there is deficiency of iron due to any reason, due to decreased dietary intake, blood loss, or any reason, whenever there is low iron is not available for the erythropoiesis, and there is iron deficient erythropoiesis, or this ultimately result into the development of anemia, microcytic hypochromic anemia, low iron, low hemoglobin, and ultimately the result of anemia. Hepcidin is one of the very important protein which play very important role in iron absorption and metabolism. It is the gatekeeper of iron metabolism. Primary source, or it's synthesized in the liver. Mechanism of hepcidin is it binds with the ferroportin and causes the degradation of ferroportin. Ferroportins are the exit channel for iron in enterocyte and macrophages. As we have discussed, during the absorption, ferroportin help the iron to transfer from enterocyte to the circulation, and they are also present into the macrophages. So if the ferroportin is degraded or not working, this will result into the decrease availability of iron. Hepcidin is the inhibitor of this ferroportin. That's why hepcidin is a negative regulator of iron. Whenever there is high iron overload or inflammation, this will increase or stimulate the more hepcidin synthesis, and ultimately this decreases iron absorption. And conversely, when there is low iron or hypoxia, this causes decreased hepcidin synthesis and iron absorption is increased. Now we will see the etiology behind the development of iron deficiency anemia. There are four main categories for iron deficiency anemia etiology. First is chronic blood loss due to any reason. This is the most common cause in high income countries. Whenever any adult male or postmenopausal female come with the complaint or findings of iron deficiency anemia, we must rule out the GI malignancy. Second category is increased demand of iron. This is particularly seen in pregnancy, infancy, and childhood and adolescent. Because of the growth, there is increased demand of the iron. Third is impaired absorption. Iron is defective in absorption. In these conditions, like celiac disease, gastrectomy due to loss of acidity promotes iron absorption. Diets high in tannates and oxalate, so these conditions impair with the iron absorption. Fourth condition is dietary intake. Low dietary intake can be seen in low income regions or individual with restricted diet like vegans and elderly individual. So these are the four main causes of iron deficiency anemia: blood loss, increased demand, impaired absorption, and dietary deficiency. Now the clinical symptoms seen in iron deficiency anemias, sign and symptoms. Neurological sign and symptoms like headache, dizziness, cognitive changes, issues with the concentration, unable to concentrate on a task. Musculoskeletal symptoms like severe fatigue, lethargy, weakness, muscle ache. Psychological or behavioral changes like irritability, restlessness, poor performance in task. In GI, loss of appetite, dysphagia can be seen. On examination, there is pallor, glossitis or angular stomatitis can be seen, and a typical finding of spoon-shaped nails known as koilonychia can also be seen in severe cases, and a feature of pica in which craving for non-nutritive items like ice, dirt and clay can be seen in the cases of iron deficiency anemia. In cardiovascular system, there is tachycardia, shortness of breath and heart murmur can be seen in the severe cases. So these are the a clinical feature of iron deficiency anemia. In the complication, there can be cardiovascular issue in severe iron deficiency anemia, pregnancy complication like preterm or low birth weight, and there can be a developmental delay in the children. Some of the clinical features, specific clinical feature of iron deficiency anemia are pica, in which craving for non-food items like dirt, ice, flour, clay is seen. Koilonychia is spoon-shaped nail. Plummer-Binson syndrome or Patterson-Kelly syndrome. This is a triad of iron deficiency anemia, atrophic glossitis and esophageal babes. How to diagnose iron deficiency anemia? Whenever patient presented with the clinical symptoms like fatigue, weakness, shortness of breath, we perform complete blood count and reticulocyte count. In iron deficiency anemia, there is decreased hemoglobin level, MCV is less than 80 femtoliter, MCH is low, and red cell distribution width is increased due to variation in cell size, and reticulocyte count is normally low or normal. On peripheral blood smear, there are microcytic hypochromic cells. Then to confirm the diagnosis, we advise serum iron studies in which there is decreased serum ferritin level, low serum iron level, low serum transferrin saturation level, and increased total iron binding capacity. So this complete blood count with iron study confirm the diagnosis of iron deficiency anemia. On morphological finding or examination, peripheral smear shows microcytic hypochromic cells. Like these are the microcytic hypochromic cells, smaller in size with increased pallor. These are the microcytic hypochromic cells. On bone marrow examination, there is absence of stainable iron on Prussian blue stain is the gold standard for diagnosis. There is no iron available in macrophages of bone marrow in iron deficiency anemia, so there is no staining, and this used as a gold standard for diagnosis of iron deficiency anemia. For the treatment of iron deficiency anemia, first to rule out the underlying cause and address the cause. Iron deficiency anemia can be due to the blood loss or dietary deficiency. After addressing the cause, there is an option of iron replacement therapy, which can be given as oral iron or in the form of the IV iron based on the requirement of the patient. The response to iron deficiency, response to the treatment are initially in first 2 to 4 weeks, lab test shows increased reticulocyte count and symptomatic improvement into the patient. In 1 to 2 weeks, there is increased hemoglobin level, and finally replenishment of the ferritin store. So this is the response of treatment. Initially increased reticulocyte count, then hemoglobin increases, and ultimately replenishes the iron stores in the form of ferritin. Now we'll see some important points for the exam NEET PG, FMGE and INICT purpose. Most common site for iron absorption is proximal duodenum. Best form of iron absorption is ferrous. Storage forms are ferritin and hemosiderin. Ferritin is the most common and soluble storage form. Hemosiderin is insoluble and normally seen in iron overload. Gatekeeper for iron metabolism is hepcidin. It decreases the iron by degrading ferroportin. Transport protein for iron is transferrin, which is synthesized in the liver. Enhancer of iron absorptions are vitamin C and gastric acid. Inhibitor of iron absorption are tannates, phytates, phosphates and calcium. First to decrease in iron deficiency anemia is serum ferritin due to decreased iron store. Second is serum iron level and increased total iron binding capacity. Third change is anemia due to decrease in hemoglobin level, and fourth change is microcytosis and hypochromic condition. Soluble transferrin receptors are increased in iron deficiency anemia but normal in anemia of chronic disease. This is a very useful marker when iron deficiency anemia and inflammation coexist. In iron deficiency anemia, there is no iron available to bind with the transferrin, so there is more free or transferrin receptors are available. That's why they increase in the iron deficiency anemia and they are normal in the anemia of chronic disease. Zinc protoporphyrin increased in iron deficiency anemia because iron is missing and zinc is incorporated into the protoporphyrin ring, and this can also be seen in the lead poisoning. Thank you. Hello everyone. In this video we will discuss megaloblastic anemia. Megaloblastic anemia is a group of disorder characterized by a common theme: impairment of the DNA synthesis, defective nuclear maturation due to deranged DNA synthesis. This results in nuclear to cytoplasmic asynchrony. The nucleus lags behind while the cytoplasm matures and accumulates hemoglobin at a normal pace, and this will result into increased cell size. The outcome of this condition is ineffective hematopoiesis and distinctive morphologic changes in all the proliferating cell lines like erythroid, granulocytic and megakaryocytic. Now we'll see the vitamin B12 absorption pathway. Dietary sources of vitamin B12 is meat, fish, eggs and milk or dairy products. Dietary vitamin B12 binds with vitamin B12 binding proteins. This complex reaches to the stomach. In the stomach, this B12 binding protein gets degraded by the pepsin, and B12 is free to bind with heptocorin. Heptocorin secretes by the salivary gland. This heptocorin vitamin B12 complex then reaches to the proximal duodenum. In proximal duodenum, pancreatic proteases cleave heptocorin and B12 is free again. This B12 now bind with the intrinsic factor which is secreted by the parietal cell of the stomach. Now this B12 and intrinsic factor complex travel to the terminal ileum. Here this complex bind with tubulin receptor on the enterocyte of terminal ileum. This complex is engulfed by the process of endocytosis, and inside the enterocyte intrinsic factor degraded and vitamin B12 is transported to the plasma with the help of transcobalamin 2. So this is the pathway of vitamin B12. absorption. Vitamin B12, or also known as cobalamin, act as a cofactor into very important biochemical reactions. The one is in which homocysteine is converted into the methionine, and in this process there is a methyl group generated, which further utilized by the deoxyuridine monophosphate to get converted into deoxythymidine monophosphate, and this is very essential in the DNA synthesis. So vitamin B12 plays an important role in DNA synthesis. Adenosylcobalamin is also a vitamin B12 cofactor. This play an important role in conversion of methyl malonyl coenzyme A into succinyl coenzyme A. Succinyl coenzyme A then utilized into the citric acid cycle or TCA cycle. Whenever there is deficiency of vitamin B12, this will result into the accumulation of methyl malonic coenzyme A or MMA and homocysteine. MMA and homocysteine then gets accumulated in vitamin B12 deficiency, and they cause the myelin damage, and this myelin damage is responsible for the neurological symptoms in vitamin B12 deficiency. What are the causes of megaloblastic anemia? So B12 deficiency and folate deficiency can result into the development of megaloblastic anemia, and there are several reasons of vitamin B12 deficiency, like in deficiency of intrinsic factor, which can be seen in pernicious anemia, post-gastrectomy or congenital intrinsic factor deficiency, distal ileum malabsorption, which is seen in Crohn's disease, ileal resection, and some malabsorption syndrome like celiac disease and Whipple's disease. In bacterial overgrowth, there is competition for the B12 absorption, and infestation with the tapeworm, they also decreases vitamin B12 absorption. And if the diet is insufficient in vitamin B12, like strict vegan or poor diet, which is seen in elderly due to poor dentition. Folate deficiency can be due to the dietary insufficiency or increased utilization, which is seen in pregnancy and lactation, malabsorption syndrome, and some condition like hypothyroidism. This is not hyperthyroidism, hypothyroidism, malignancies, chronic hemolysis, and exfoliative dermatitis. Some drugs like antifolates, anticonvulsant, and sulfasalazine also impair the DNA synthesis and will result into megaloblastic anemia. This we have already discussed. B12 is found in animal products like meat, eggs, and dairy products. Humans have several years worth of B12 stored in liver. The absorption pathway we have already discussed. Like, here are the key events of B12 absorption. Like in stomach, pepsin frees B12 from the food protein, and B12 binds to the heptocorrin. In duodenum, pancreatic proteases release B12 from the heptocorrin, and B12 bind to the intrinsic factor, which is secreted by the parietal cells of stomach. In the ileum or terminal ileum, intrinsic factor and B12 complex bind to the tubulin receptor and is absorbed. In plasma, B12 associated with the transcobalamin for delivery to the liver and the tissues. The pathophysiology of vitamin B12 deficiency anemia. Causes of vitamin B12, as we have already discussed, can be due to malabsorption, pernicious anemia, which is seen in which result into the intrinsic factor deficiency. Dietary deficiencies, they all will result into B12 deficiency. Due to vitamin B12 deficiency, there is impaired DNA synthesis, and this will result into ineffective hematopoiesis. Nuclear to cytoplasmic asynchrony, in which nuclear maturation lags behind the cytoplasmic maturation and ultimately culminate into increased cell size of all erythroid, granulocytic and megakaryocytic lineage. On peripheral smear, there are macrocytes, megaloblast and low hemoglobin on CBC. Due to anemia, there is fatigue, weakness and shortness of breath is there. As we have discussed, vitamin B12 deficiency will result into the increase MMA and homocysteine level, and they causes myelin damage. So there are neurological effects which is seen in B12 deficiency only, not in the folate deficiency. There is a condition known as subacute combined degeneration of the spinal cord is seen in B12 deficiency. Neurological effects manifest as numbness, paresthesia and ataxia. Morphological features of vitamin B12 deficiency or megaloblastic anemia. Regardless of all the causes of B12 or folate, the peripheral smear and bone marrow shows the classic findings. In peripheral smear in RBC, there are macrovelocytes, large oval shaped cells, and there is anisopoikilocytosis, marked variation in size and shape, which is reflect as increased red cell distribution width on the CBC. Reticulocyte count is normally low, reflecting ineffective production. Neutrophil shows hypersegmentation, more than 5 nuclear lobes. Bone marrow is hypercellular due to increased hematopoietic precursor. There are promegalocytes, large RBC precursor with fine lace-like nuclear chromatin, and there are giant forms of giant metamyelocytes, belt form, large and some large and bizarre megakaryocytes are also seen. So on peripheral smear, there are macrocytes, RBC size increase, some macroovelocytes. Some of the RBC shows bluish stippling known as basophilic stippling. Normoblast can also seen, immature RBC secreted into the peripheral smear. This is the hypersegmented neutrophil having more than 5 nuclear lobes, 1, 2, 3, 4, 5, 6. So these are the classical findings of megaloblastic picture. Now we will see the diagnostic approach to megaloblastic anemia. Patient presented with fatigue, weakness, pallor on complete blood count, MCB or mean cell volume is increased more than 100 femtoliter, and there is anemia, decreased hemoglobin. On peripheral smear, there are macrocytes, macrovelocyte, hypersegmented neutrophils. After peripheral smear and complete blood count, we order for the reticulocyte count, which is usually low or normal. On serum biochemistry, serum vitamin B12 and folate level, if the serum vitamin B12 level is decreased less than 200 picogram per ml, this suggests vitamin B12 deficiency. If the serum folate level is decreased, this suggests folate deficiency. If the serum biochemistry is in the gray zone or inconclusive, then we measure the other metabolites like methyl malonic acid and homocysteine. If these two are elevated, this suggests the vitamin B12 deficiency. Then we further identified the cause and address the cause for the treatment. If the MMA or homocysteine is normal, then this suggests the folate deficiency. So this is all about the vitamin B12 folate deficiency anemia, megaloblastic anemia. Thank you. In this video we will discuss beta thalassemia. So beta thalassemia is a group of hereditary hemolytic anemias characterized by a genetic deficiency in the synthesis of beta globin chains. This imbalance or decreased beta globin chain synthesis leads to two primary pathological consequences. One is reduced hemoglobin production causing microcytic and hypochromic anemia, and the accumulation of the unpaired alpha globin chains which precipitate and destroy the red cell precursor in bone marrow and in the spleen. As we know, adult hemoglobin HbA is composed of 2 alpha and 2 beta globin chains. Thalassemia is commonly found in Mediterranean, African area, Southeast Asia. Gene for beta globin chain are present on chromosome 11, and genes that coded alpha globin chains are present on chromosome 16. There are two other type of hemoglobin that we will discuss, or they play an important role to understand beta thalassemia. One is HbA2. In HbA2, alpha 2 and delta 2 globulin chains are present. In HbF, alpha 2 and gamma 2 globulin chains are present. Now we will see the molecular pathogenesis of beta thalassemia. The primary defect is reduced or absent synthesis of the beta globin chains. There are two types of genotypes that we are going to use again and again. Beta 0, this signifies total absence of beta globin, and beta plus, this signifies the reduced but detectable beta globins. Key mutation in beta thalassemia is point mutation. This is the most common cause of beta thalassemia pathogenesis, unlike alpha thalassemia, which is usually caused by gene deletion. So there are three types of point mutation: splicing mutation, chain terminator, nonsense or frame shift mutation, and third is promoter mutation. So in splicing mutation is most commonly caused beta plus type of genotype. Chain terminator mutation is the most common cause of beta 0 type of genotype, and promoter mutation they seen in beta plus type of genotype. Beta thalassemia or thalassemia is an autosomal recessive disease. Pathophysiology of beta thalassemia. The two-fold anemia is seen in beta thalassemia. As we know, in beta thalassemia there is decrease or no synthesis of the beta globin chain. If beta globin chain is decreased or absent, there is decreased production of the adult hemoglobin or HbA, and there will be anemia. Mainly microcytic hypochromic anemia seen in beta thalassemia. The other mechanism is due to decreased beta chain, there is increase alpha or unpaired alpha globin chain is there. They form an aggregate which is insoluble and cause damage to the RBC or RBC precursors by various mechanisms, primarily by the membrane damage, and this increases the apoptosis of RBC precursors, and some damaged RBCs are destroyed in the spleen, resulting into extravascular hemolysis. So both of these mechanisms result into an anemia. Now, as we have discussed the pathophysiology, which is depicted in this diagram, alpha is normal and beta chain is reduced or absent. So impaired beta globin synthesis will result into decreased HbA synthesis and development of microcytic hypochromic anemia. Another mechanism is unpaired alpha globin chains causes damage to the RBC membrane or red blood cell precursors in the bone marrow. Damage to these precursors promotes the apoptosis, and this will result into the compensatory erythroid hyperplasia into the bone marrow. Due to this erythroid hyperplasia, there is increased secretion of erythroferron, which is secreted by RBC precursors. This erythroferron decreases hepcidin, and low hepcidin level will result into increased iron absorption. As the alpha globin aggregates causes damage to RBC or precursors, this also causes anemia. And to compensate the anemia, there is extramedullary hematopoiesis. And as we have already said, these damaged RBC, when travel through the spleen, are phagocytosed by the macrophages and result into the hemolytic anemia, extravascular hemolysis. So iron overload we will discuss into the complication. The clinical features are the typical clinical features of the anemia: pallor, weakness. As this is hemolytic anemia, jaundice can be seen, icterus can be seen. Now we have two types of beta thalassemia to discuss: beta thalassemia major and beta thalassemia minor or trait. Genotype of beta thalassemia major is homozygous beta 0 or homozygous beta plus or double heterozygous beta plus or beta 0. In beta thalassemia minor, one beta globin gene is normal and other can be deficient or completely absent. Beta 0 or beta plus, heterozygous. Beta thalassemia major is a severe transfusion dependent condition, and in beta thalassemia minor, mostly patients are asymptomatic, and this is an incidental finding most of the time. Beta thalassemia minor. On HB electrophoresis or HPLC, there is increased HbF level in beta thalassemia major, mostly more than 90%. The primary hemoglobin is HbF in beta thalassemia major, but in beta thalassemia minor, HbA2 is seen in the range of 4 to 9 or 4 to 8% with normal or slightly increased HbF. Clinical onset of symptoms is after 6 to 9 months in beta thalassemia major, and as we have already said, beta thalassemia minor or trait is an incidental finding, mostly asymptomatic. Beta thalassemia intermedia is holding the middle ground in the severity between beta thalassemia minor and major. Interestingly, if the co-inheritance of alpha thalassemia is present with beta thalassemia, this improves the symptom by reducing the chain imbalance. Beta decrease, alpha decrease, so there is no or low alpha aggregates, so there is no damage to the RBC membrane. Now we will see the morphological and radiographic findings in beta thalassemia. Primary cell type is microcytic hypochromic cells. Microcytic hypochromic cells along with the basophilic stippling target cells, microcytes, and variation in size and shape of the cell, which is known as anisopoikilocytosis. In the case of beta thalassemia measure, there is excessive erythroid hyperplasia may result into the presence of normoblast in peripheral blood. On X-ray, due to massive marrow expansion, the marrow erode the cortex and result into the crew-cut appearance on the skull bone. So these hair-like projections, we can see. This is known as crew-cut appearance on skull X-ray because of the massive marrow expansion that erode the cortex. As the anemia promotes extramedullary erythropoiesis, this will result into the hepatosplenomegaly. Now we will see the diagnostic approach to beta thalassemia. Patient present with the clinical symptoms of anemia on complete blood count, so microcytic hypochromic anemia with low RBC indices, MCB, MCH. On peripheral ischemia, there are target cells, basophilic stippling, anisopoikilocytosis, normoblast, and polychromasia. Now our main two differential diagnoses are beta thalassemia and iron deficiency anemia. On HPLC or hemoglobin electrophoresis, in normal individual or in iron deficiency anemia, there is HbA is around 98% or 95%. HbA2 is somewhere between 2 to 3.5%, and HbF is up to 2%. But in case of the beta thalassemia minor, HbA2 is between 4 to 8%, and in beta thalassemia major, which has more severe clinical symptoms, and this patient is particularly transfusion dependent, showing HbF around 95% in HPLC graph. Difference between thalassemia minor and iron deficiency we will discuss later. Molecular genetics also play an important role in prenatal diagnosis and to identify the specific mutation in beta thalassemia. Okay, now we see the various HPLC graph. HPLC is a better technique than, or more advanced technique than hemoglobin electrophoresis. So this is the normal graph of a healthy individual. We need four things to read an HPLC graph, or these are the prerequisite to read an HPLC graph. Baseline supposed to be properly constructed. Second thing is A2 peak. This is the A2 peak. A2 peak should be present. P3 value. P3 value is less than 8%. More than 8% P3 value indicates contamination of sample. Area or total area is between 1 to 4 million. So this is the HPLC graph of normal individual. Now we will see the HPLC graph of beta thalassemia trait. This is showing A2 value 4.9%, and most of the hemoglobin is HbA around 83%. So HbA2 value 4.9 with a normal HbF is suggestive of thalassemia trait. In thalassemia major, the main hemoglobin is HbF, and in thalassemia intermedia there is increase HbA2 4.7% and HbF is 25%. So in beta thalassemia intermedia there is increase HbA2 between 4 to 9%, and HbF is also raised somewhere between 10 to 30%. Now we'll see the complication of thalassemia, beta thalassemia. Iron overload is the very common and severe complication of beta thalassemia, and there are two mechanisms by which there is iron overload in beta thalassemia. The first is, as the decreased synthesis of beta chain will result into decreased hemoglobin. This causes anemia, and to treat this anemia, patient require chronic or repeated transfusion. This will result into iron overload. And the other mechanism is, as we have discussed, there is erythroid hyperplasia in beta thalassemia. So in erythroid hyperplasia, there is increased erythroid precursor. They release erythroferron, which decreases the hepcidin and result into the increased absorption of iron from the gut and causes iron overload. This iron overload is known as secondary hemochromatosis, and this secondary hemochromatosis causes damage to heart, which is the most common cause of death in beta thalassemia. This secondary hemochromatosis may involve liver and pancreas. Now we will see the difference between thalassemia minor or thalassemia trait and iron deficiency anemia. Thalassemia minor is also known as thalassemia trait. So on morphology, both of them are showing microcytosis, hypochromia, target cells can be seen in both the condition. But in iron deficiency anemia, there are pencil cells, annulocytes, and in beta thalassemia there is basophilic stippling, which is usually not seen in iron deficiency anemia. Polychromasia is there, and sometimes nucleated RBC can be seen in thalassemia trait. So on complete blood count, hemoglobin is decreased in both the condition, and RBC count is decreased in iron deficiency anemia, but in beta thalassemia RBC count is increased, which is disproportionate to the level of HB. RBC count is unusually high in beta thalassemia trait or beta thalassemia because this is an hemolytic anemia. This is a hemolytic anemia, and due to hemolysis, bone marrow produces more and more RBC. So count is usually normal or increased in thalassemia. MCB, MCHC is decreased in both the condition, and there is RDW is particularly high in iron deficiency anemia, means there is wide variation in the size and shape of the RBCs. RDW usually normal or slightly high in thalassemia trait. On biochemistry, ferritin, serum iron and ferritin is decreased in iron deficiency anemia. TIBC is increased in iron deficiency anemia. TIBC stands for total iron binding capacity. In thalassemia, ferritin is normal or iron is usually high because of the iron overload. On electrophoresis, thalassemia clearly shows, based on which type of thalassemia, whether it is minor, intermediate or major. There are peculiar HPLC finding like increased HbA2 or HbF. The main cause in iron deficiency anemia is depletion of the iron or decreased iron deficiency. And in beta thalassemia, as we know, this is an hemoglobinopathy due to decreased beta globin chain synthesis. Beta thalassemia require genetic counseling because this is an inherited disease. One important index is also known as Menzer index, calculated by MCV divided by RBC count. This is normally more than 13 in iron deficiency anemia and less than 13 in thalassemia minor. So what are the treatment options? We will not discuss detail about the treatment option, but as we know, thalassemia major need frequent transfusion The frequent transfusion can result into the iron overload, so we need chelation, iron chelation, which is achieved by deferrasirox, which is oral, or deferriprone, which can be given oral or in the form of injectable, and deferoxamine, which is an injectable liquid. Folic acid supplementation is also help in the management of beta thalassemia, as the folic acid promote synthesis of the new RBC. Hematopoietic stem cell transplantation is the curative option for the treatment, and in the newer modalities, gene therapy is there. Basically, this technique modifying the patient's stem cell to produce healthy hemoglobin. So there are two drugs, betiveglogene autemcel, also known as Zynteglo. This is an FDA approved drug for the transfusion dependent patient. FDA approved treatment option for the transfusion dependent patient, and the other one is hexagamglogene autotemcel, also known as Casgevy, a CRISPR based gene editing therapy usually advised for the patient 12 years or older. So this is brief about the treatment. Thank you for watching. Hello everyone, in this video we discuss about the alpha thalassemia. So this is an inherited disorder characterized by a reduced or absent synthesis of alpha globin chains, leading to a spectrum of clinical presentation based on gene deletion severity. Normally, in adult hemoglobin HbA, there are 2 alpha chain and 2 beta chain. In alpha thalassemia, there is absent or reduced synthesis of these alpha chains. So what is the pathophysiology behind alpha thalassemia? The normal individual possesses 4 alpha globin genes, 2 on each chromosome 16. Alpha thalassemia results from inherited deletions affecting these genes with severity directly proportional to the number of deleted genes. More number of genes deleted will result into the more severe disease. In the molecular mechanism, the gene deletion is the most common cause of alpha thalassemia development. As in beta thalassemia, anemia stems from inadequate hemoglobin synthesis and the excess of unpaired alpha chain. But in alpha thalassemia, there is decreased alpha chain and there are excess of unpaired beta, gamma and delta chains that vary according to the age of the patient. In this diagram, we will discuss about the pathophysiology of the alpha thalassemia. Normally, chromosome 16 have 2 alpha globin gene. So 1 pair of chromosome 16 result into the total 4 number of alpha globin genes. These 4 alpha globin genes will result into the production of 2 alpha globin chains. Normally, there is balanced or enough production of alpha globin chains, and there is formation of HbA when alpha 2 pair with the beta 2 chains. And in healthy blood RBC, there is HbA or adult hemoglobin, which is composed of 2 alpha chain and 2 beta chain. Unlike alpha globin, beta globin is encoded by 2 beta globin genes, and alpha globin chain is encoded by 4 alpha globin genes. So based on the number of deleted alpha globin gene, there are 4 types of alpha thalassemia. First condition is silent carrier, in which only one alpha globin gene is deleted. This is a very mild condition, mostly asymptomatic, and there is only near normal hemoglobin production in this condition is seen. The second condition is alpha thalassemia trait or carrier. In this condition, 2 alpha globin gene is deleted. 2 alpha globin gene deleted in alpha thalassemia trait. This is the similar condition as the beta thalassemia minor. Clinically, there is microcytosis on peripheral smear and mild anemia with pale RBCs. Third condition is when 3 alpha globin gene is deleted, is known as hemoglobin H disease or HbH disease. In this condition, severe decrease in the alpha globin chain is there, and due to decreased alpha globin chain, there is excess of beta globin chain. These beta globin chain form tetramer and they destroy the RBC. They damage the RBC membrane and will result into the hemolysis. And these inclusions, beta 4 inclusion in the RBC, will result into the phagocytosis of RBC when they travel through the spleen or during the splenic sequestration, and further causes hemolysis and ultimately anemia. The fourth condition or fourth type of alpha thalassemia is alpha thalassemia major, or also known as hemoglobin warts or hydrops fetalis. There is no alpha globin production in this condition, as all four alpha globin genes are deleted. All 4 alpha globin genes are deleted in this condition. So there is excess gamma chains, as this gamma pair with the alpha chain and form HbF, a fetal hemoglobin. So in this condition, there is no alpha chain, so there are formation of excess gamma or gamma tetramers. Gamma tetramers have very high affinity for the oxygen, so there is no oxygen available for the tissue. This will result into the high output cardiac failure and edema. This condition known as hydrops fetalis. Mostly in this condition there is death in utero or there is stillborn cases. So these are the 4 conditions we have discussed based on the number of alpha globin gene deleted. In silent carrier there is 1 alpha globin gene deleted. In alpha thalassemia trait or carrier, 2 alpha globin gene deleted. In HbH disease, 3 alpha globin gene deleted. And alpha thalassemia major or hydrops fetalis, all 4 alpha globin genes are deleted. No alpha globin chain production in the hydrops fetalis. As in newborn, there is excess gamma globulin. They form gamma 4 tetramers. This condition is seen in hydrops fetalis or hemoglobin warts. As we know, the main hemoglobin in utero or early life is HbF. HbF is composed of 2 alpha and 2 gamma chains. So if there is no alpha, then excess of gamma is there, and this will result into the formation of gamma tetramers. In the childhood and adult, we know the main hemoglobin is in childhood and adult life is HbA, which is composed of alpha 2 and beta 2 chains. If alpha is decreased, then there is excess of beta, and beta 4 tetramers are seen, which is seen in HBH disease. These free beta and gamma chains have formed stable hemotetramer and causing the less severe hemolysis than the beta thalassemia. As in beta thalassemia, there are alpha tetramers, because there is in beta thalassemia, beta chain is decreased, so there are alpha tetramers in beta thalassemia. They are slightly more unstable and result into the more RBC membrane damage and more severe hemolysis. Clinical syndrome classification in alpha thalassemia. The clinical presentation and severity of alpha thalassemia are determined by the number of alpha globin gene deleted. Each of the 4 alpha globin genes normally contribute 25% of the total alpha globin chain synthesis. As the number of deleted gene increases, the clinical manifestation progress from asymptomatic to life-threatening condition. These we have already discussed. In silent carrier state, only 1 alpha globin gene deleted. This is mostly an asymptomatic condition. This is the mildest form of alpha thalassemia with minimal clinical impact. Alpha thalassemia trait: 2 alpha globin gene deleted. In this condition is identical to the beta thalassemia minor with microcytosis and having minimal or no anemia. HbA2 level is normal in this condition. HBH disease, in this condition, 3 alpha globin gene deleted. This is the most commonly seen in Asian population, and there is markedly reduced alpha chain synthesis. So there is formation of beta tetramer. Beta tetramer seen in the form of golf wall on supravital staining. These inclusion are beta tetramers. As we know, beta globin, as we have discussed, beta globin tetramers have high affinity for the oxygen, so there is less oxygen available for the tissue, and this result into a tissue hypoxia. And these intracellular inclusion of the RBC promote splenic sequestration and phagocytosis. Clinical severity of HBH disease. This is a moderately severe anemia resembling beta thalassemia intermedia or significant. In this condition, there is significant hypoxia with hemolytic components. Now the hydrops fetalis. This is the most severe form of the alpha thalassemia. All 4 alpha globin genes gone. In this condition, excess of the gamma globin chain is there, as the HbF is the main hemoglobin of early life, and this gamma chains have a very high affinity for the oxygen, so there is this result into the tissue hypoxia or anoxia, and ultimately result into the hepatosplenomegaly. Most of the cases there is death in utero is the outcome, but with the modern management, intrauterine transfusion now enable survival of the many affected infants, but these need lifelong transfusion dependence. requires regular blood transfusion for survival with associated risk of iron overload and organ damage. The curative option for this condition is hematopoietic stem cell transplantation. Key features for this alpha thalassemia is, as we have discussed, severity of symptoms is directly related with the number of alpha globin gene deleted. HBH disease, when the 3 alpha globin gene is deleted, this will result into the HBH disease. This is similar to the beta thalassemia intermedia. Hydrocephalus is medical emergency. All 4 alpha globin genes are deleted and result into the lethal fetal anemia. Intrauterine transfusion and stem cell transfusion offer treatment options. So this is alpha thalassemia for you. Thank you for watching. Sickle cell disease is a common hereditary hemoglobinopathy caused by single point mutation in beta globin gene. A GAG codon is mutated to GTG, resulting in substitution of normal charged hydrophilic glutamate residue with the hydrophobic valine residue. Glutamate is replaced by valine. As a consequence, the subtle amino acid change dramatically altered physiochemical properties of resulting sickle hemoglobin, setting the stage for polymerization. In the molecular pathogenesis, the mutation in the 6th codon of beta globin gene on chromosome 11, replacement of glutamic acid with valine. Whenever these patient or these individual exposed to hypoxia or deoxygenation, this will result into the polymerization of HBS or sickle hemoglobin into long needle-like structure and result into RBC cytosol liquid to viscous gel. Liquid cytosol convert into viscous gel. Repeated or persistent hypoxia result into the formation of needle-like crystal and they damage the RBC membrane. RBC membrane damage will result into calcium influx and potassium and water efflux, and ultimately irreversibly sickle cells will be there. Irreversibly sickle cell formation will be there on persistent hypoxia. Normally in a beta globin gene, a glutamate is present on the 6th codon. In sickle cell, there is glutamate is replaced with valine. These individuals with HBS or sickle hemoglobin exposed to hypoxia result into the formation of fiber, needle-like fiber formation, and these damage the RBC membrane and result into calcium influx and potassium and water efflux and dehydration of the cell. Long-standing hypoxia result into permanent sickling of the cell. Irreversibly sickle cell are phagocytosed by various mononuclear phagocytes in spleen or bone marrow, result into extravascular hemolysis, which manifests as hyperbilirubinemia and gallstone. These RBCs are fragile due to membrane damage and may result into intravascular hemolysis and release free hemoglobin into the plasma. This free hemoglobin binds with the nitric oxide and decreases the level of nitric oxide, which result into increase platelet aggregation and altered vascular tone, and play an important role in development of microvascular occlusion. Based on the site, this microvascular occlusion causes ischemic tissue damage like acute chest syndrome in lung, dactylitis and pain crisis in bone, acute congestion and autosplenectomy in the spleen, and may result into the stroke when brain is involved. So the mechanism behind vaso-occlusion in sickle cell anemia or sickle cell diseases: sickle cell express increased adhesion molecule, and they decreases the nitric oxide due to free hemoglobin, which causes increased platelet aggregation. Both of these mechanism will play an important role in development of vaso-occlusive crisis. These sickle cell have damaged membrane, and they express increased adhesion molecule and have increased stickiness for endothelium. Whenever there is a slow flow, or particularly in inflamed site, spleen, bone marrow, there is high chances of vaso-occlusion. Now, what are the factors affecting or influencing sickling? So MCHC, mean cell hemoglobin concentration. Increased MCHC increases sickling because of dehydration. pH acidosis shifts curve to right side and promoting deoxygenation and increases the sickling. Fetal hemoglobin and adult hemoglobin, they inhibit HbS polymerization, and that's why decrease the sickling. Coexisting alpha thalassemia will result into decrease MCHC, and that's why reducing the severity of sickle cell disease. And on the other hand, if alpha chain is low, so there is no alpha chain available for pairing with the beta chain, so ultimately decreases the risk of development of sickling. Transit time: sluggish flow promotes sickling. Sluggish flow are particularly present in spleen, bone marrow and inflamed sites. As we have discussed, sickle cell have more adhesion molecule, and they have increased tendency to stickiness. Morphology and finding on peripheral smear: RBCs are sickle shaped RBC or holly leaf shaped RBCs. They can be target cell due to dehydration. Oval-jolly body, small nuclear remnants indicate functional splenia. Bone marrow can show erythroid hyperplasia due to hemolysis. On X-ray, crew-cut appearance of the prominent skull and prominent cheekbone can be seen. Crew-cut appearance is also seen in thalassemia. These are the peripheral blood smear finding. Target cells, oval-jolly body, these are the nuclear remnants. Reticulocytes is also increased due to because of the hemolysis. There is increased erythropoiesis. So reticulocytes release in the peripheral circulation. Clinical manifestation or the various crises involved in or seen in sickle cell disease. Very important is vaso-occlusive crisis. This is most common and causes wound pain, dactylitis, also known as hand-foot syndrome in infants, acute chest syndrome, manifest as fever, chest pain, pulmonary infiltrate. Leading cause of death in adult is acute chest syndrome. sequestration crisis, massive RBC trapping in the spleen and result into sudden splenomegaly and hypovolemic shock, which is common in children. So splenomegaly and hypovolemic shock is common in children. Acute chest syndrome is the leading cause of death in adults. Aplastic crisis seen in individual of sickle cell disease, which is triggered by parvovirus B19 infection and result into sudden drop in reticulocyte. What are the systemic complications seen in sickle cell disease? Spleen show early congestion, chronic infarction and autosplenectomy. Spleen reduced to fibrous nubbin by the adulthood. Infection, increased risk of encapsulated organism, Streptococcus pneumoniae or Haemophilus influenzae due to asplenia. Kidneys, there is hyposthenuria, inability to concentrate the urine due to renal medullary damage. Bones show increased risk of Salmonella osteomyelitis and due to extravascular hemolysis, formation of gallstone, pigment stone. Diagnosis and screening of sickle cell disease. In the screening, use solubility test or sodium metabisulfite test to see the sickling of RBC. Gold standard is hemoglobin electrophoresis or HPLC, which show HBS, increase HBS. Prenatal diagnosis, DNA analysis by amniocentesis, and in the newborn there is newborn screening, which is routinely followed in many healthcare sector or setup. So for screening, sodium metabisulfite test or sickling test. Gold standard is hemoglobin electrophoresis or HPLC. Prenatal screening, DNA analysis by amniocentesis, and newborn screening from the heel stick screening. Management of sickle cell disease. Hydroxyurea is the mainstay of treatment of sickle cell disease. Hydroxyurea increases HbF level and has anti-inflammatory effects. HbF decreases the polymerization of HbS and ultimately decreases sickling. L-glutamine reduces oxidant stress and pain crisis. Supportive treatment is hydration, analgesics, prophylactic penicillin at the age of 5 can be given. Vaccination against encapsulated organism, as due to asplenia, infection of encapsulated organism can be increased in sickle cell disease. Definitive and emerging treatments are hematopoietic stem cell transplant, and new treatment modalities are gene editing, reverse hemoglobin switching to produce HbF. Now we will see the mechanism of falciparum malaria protection in sickle cell individual. Normally, the malaria parasite decreases oxygen or consume oxygen inside the RBC and cause a condition of hypoxia or deoxygenation, which induces sickle cell formation, and these sickle cell with parasite are cleared by the phagocytes of the spleen. So this decreases the load of parasite. And the second mechanism is normally RBC with the help of PFEMP1 protein, which is a parasite made protein, form a membrane node which increases the adhesion of these RBC to the endothelium of cerebral vessels. But in sickle cell there is impaired knob formation and ultimately decreases the adhesion of these RBC or sickle cell and decreases the risk of development of cerebral malaria. So by these two mechanisms, sickle cell individuals are protected against falciparum malaria. One is the malaria causes hypoxia and promotes sickling, and these sickle cells are cleared by the phagocytosis and decreases parasite load. And the second mechanism is sickle cell has impaired nerve formation and ultimately decreases cell adhesion. So the incidence of cerebral malaria is decreases in sickle cell. Now we'll see the important points of a sickle cell disease. Mutation at the 6th codon of beta globin on chromosome 11, glutamate is replaced by valine. The sickling is commonly caused by or triggered by hypoxia, acidosis, dehydration. Autosplenectomy in adults or children is seen due to vaso-occlusive crisis. Infection of or increased risk of infection with encapsulated organism like Streptococcus pneumoniae, H. influenzae, and bone infection with Salmonella is there. Crooked appearance seen on the skull X-ray, and hydroxyurea is the mainstay of treatment. Hello everyone, in this video we will discuss about the paroxysmal nocturnal hemoglobinuria or PNH. So by definition, this is an acquired clonal hematopoietic stem cell disorder characterized by a triad of intravascular hemolysis, venous thrombosis, and the bone marrow failure. This is the only hemolytic anemia caused by an acquired genetic defect. Only hemolytic anemia caused by an acquired genetic defect. Now we'll see the pathophysiology of PNH. Gene mutation seen in PNH is a somatic mutation in PIGA, stands for the phosphatidyl inositol glycan class A gene. So PIGA gene is mutated in PNH. This gene is present on the X chromosome. As we have already said, this is an acquired genetic disorder, not an inherited genetic disorder. So PIGA gene is essential for the synthesis of GPI anchors, glycosyl phosphatidyl inositol anchors. So deficiency of these GPI anchor will result into the loss of GPI linked surface protein. So this is PNH is a disorder of hematopoietic stem cells. That's why it affects all the cell lineages, RBC, WBC, and platelets. So what are the GPI linked proteins? In PNH, the loss of these specific complement regulatory protein is critical, known as, the first is CD55, also known as decay accelerating factor. This inhibits C3 and C5 convertases. CD59, also known as membrane inhibitors of reactive lysis. This is the most important GPI linked protein involved in the pathophysiology of PNH. This prevents the formation of membrane attack complex. And the third GPI linked protein which is deficient is C8 winding proteins. So due to their deficiency, there will be an abnormal activation of the complement and there will be hemolysis. So this is the flow chart of PNH pathophysiology. As we have discussed, this is an acquired somatic mutation in hematopoietic stem cell in the PIGA gene, and this will result into the defective GPI anchor proteins and ultimately absence of the GPI anchored proteins on the blood cells. GPI deficient red blood cells, they have low or absent CD55 or CD59. Normally CD55 is inhibit the C3 convertase and C5 convertase and prevent the activation of the complement system. CD59 normally this inhibit the formation of the membrane attack complex. Whenever this CD59 is deficient in PNH, there will be an excessive activation of the membrane attack complex, and this causes the hole in RBC and result into intravascular hemolysis. As we have discussed, due to the decreased GPI anchored protein CD55 and CD59, there will be uncontrolled complement activation. This will result into the chronic hemolysis. This can be intravascular by membrane attack complex mediated, or the extravascular due to the lack of inhibition of the C3 convertase. As C3V act as opsonization, and this will result into the increased phagocytosis of red cell by the macrophages of spleen and liver. So in intravascular hemolysis, there is direct lysis of the RBC due to activation of the MAC, and hemoglobin released into the blood stream result into the hemoglobinuria or hemosideruria. This free hemoglobin bind nitric oxide and ultimately result into the decreasing nitric oxide level. Due to low nitric oxide level, there will be smooth muscle dystonia in the form of esophageal spasm and erectile dysfunction, and the elevated level of LDH and bilirubin, low haptoglobin are also seen in the intravascular hemolysis. So these are the we have discussed about the hemolysis and anemia. Now, due to uncontrolled complement activation, there will be thrombophilia or venous thrombosis. As we have discussed, the free hemoglobin binds with the nitric oxide and result into the decreased level of nitric oxide. So there will be more platelet aggregation, and there is increased chances of the formation of the thrombus. The common sites for the thrombosis is hepatic vein, Budd-Chiari syndrome, portal vein, mesenteric vein, and cerebral vein. Due to uncontrolled complement activation, as we have discussed, this PNH is a disorder of hematopoietic stem cell. There can be a marrow failure, hematopoietic stem cell dysfunction, or increased apoptosis, ultimately result into the pancytopenia, decrease in the RBC, WBC, and the platelet count. Treatment option for the PNH is C5 inhibitors like eculizumab, ravulizumab. They block the MAC formation and decrease the intravascular hemolysis. Another group is proximal C3 inhibitors, pegcetacoplan. This inhibits C3 convertase and C3V opsonization. So this will help into the controlling both intravascular and extravascular hemolysis. So this is the diagrammatic representation of the paroxysmal PNH pathophysiology. Now we'll see the clinical features of the PNH. Features of anemia, particularly hemolysis, which is chronic intravascular hemolysis, and only the 25% of the cases have nocturnal paroxysm. Mechanism behind the nocturnal hemoglobinuria is in the night there will be slight decrease in the pH. pH is slightly decreased in the night, and this will result into the activation of complement system. and so there will be hemolysis. Thrombosis is the leading cause of death in PNH, and the common sites are hepatic, portal vein and cerebral vein. Bone marrow failure is frequently associated with the aplastic anemia, and on the long run 5 to 10% cases of PNH may develop into the AML or myelodysplastic syndrome. This also suggests that the pathogenesis is somewhere into the hematopoietic stem cell. So ultimately they result into the AML and myelodysplastic syndrome. How to diagnose PNH or paroxysmal nocturnal hemoglobinuria? Gold standard for diagnosis is flow cytometry. They detect the absence of CD55 and 59 on the RBC or granulocyte. The most sensitive test is fluorescent proaerolysine that bind directly to the GPI anchors. Classically, there are some tests like Hames test, acidified serum test, and sucrose hemolysis test, now mostly replaced by the flow cytometry. And other biochemistry or clinical biochemistry finding, they involved in the urine. There is increased hemosideruria, or there will be hemosideruria, ultimately leading to the iron deficiency, and there is decreased heptoglobin level and increased LDH level in the serum. So as we can see, there is in the PNH CD59 is deficient. This is the flow cytometry image of the this is the image of RBC showing CD59 deficient population. The neutrophil CD in flare. This is the deficient population. So how to manage or treat a case of PNH? Targeted therapy like eculizumab is a monoclonal antibody that work against the C5 and prevent the conversion of C5 to C5a and C5e, and ultimately block the formation of membrane attack complex. This reduces the hemolysis and the thrombosis risk by the 90%. So eculizumab is very important drug, but this increases the chance of meningococcal infection. So the vaccination is mandatory before starting the treatment with meculizumab. And as we have discussed, due to chronic hemolysis, there can be iron deficiency, anemia. So in supportive therapy, we provide iron and folate supplementation. Hematopoietic stem cell transplant is the curative option of management. Now high yield points for the NEET PG exam. The mutated gene in PNH is PIGA gene, which is X-linked, and this is an only acquired genetic hemolytic disorder. Most important protein is CD59, also known as membrane inhibitor of reactive lysis. Screening test is flow cytometry, or most sensitive or best test is flare. Cause of death is venous thrombosis. Flare is also flow cytometry. Drug of choice is eculizumab. Association of PNH is with the aplastic anemia because of the bone marrow failure, and long run may convert into the AML or MDS, and urine findings are the hemosideruria may result into the chronic iron deficiency. Thank you for watching the video. Thank you. Hello everyone. In this video we will discuss hereditary spherocytosis. So welcome on the video. So what is the pathology and genetics behind the hereditary spherocytosis? The most common inheritance followed in hereditary spherocytosis is autosomal dominant, and some of the cases are showing autosomal recessive inheritance. Primary defect is in the vertical membrane proteins of the RBC membrane, and the most common protein deficiency is ankyrin. Other defected proteins are band 3, beta spectrin, and protein 4.2. So this is the diagram of RBC membrane structure, in which there are certain proteins like spectrin, these two band of spectrin, alpha and beta. This is ankyrin, and this is protein 4.2, and this is the band 3 protein. So these proteins are essential for the membrane stability or structural stability to the RBC membrane. Whenever there is deficiency of any of these proteins, this will result into the increased RBC membrane instability and result into loss of the RBC membrane when as the cell ages. So ultimately cell assume a size of a spherocyte which is geometrically efficient for volume to surface ratio. So cell become spherocytes from the biconcave cell due to loss of the RBC membrane. These spherocytes are inflexible and usually trapped into the narrow cords of splenic sinusoids. These trapped RBCs then phagocytose by the splenic macrophages and result into extravascular hemolysis. So what are the clinical signs, symptoms and findings are seen in hereditary spherocytes? A triad of anemia, as this is a hemolytic anemia, and due to hemolysis there is jaundice and splenomegaly, as we have discussed, RBC trapped into the spleen and phagocytosed by the splenic macrophages. Splenomegaly is more consistent and prominent in hereditary spherocytosis than almost any other hemolytic anemia. So splenomegaly is a very consistent finding in hereditary spherocytosis. As we have discussed, this is a case of hemolytic anemia. Due to hemolysis there is increase in bilirubin, and ultimately this will form gallstone, pigment gallstone, calcium bilirubinate stones, around 50% of the patients. Aplastic crisis can also seen in hereditary spherocytosis when the infection of parvovirus V19 is there, and this is identified by the drop in the reticulocyte count. Megaloblastic crisis can also seen, as we have discussed. There is increased hemolysis which promote the bone marrow to form new erythrocytes. So there is erythroid hyperplasia, and high cell turnover may result into folate deficiency and megaloblastic condition. To diagnose this condition, on peripheral smear there are spherocytes, small hyperchromic RBCs like center pallor. As we can see, these are the spherocytes, no center pallor, and usually small in this size of, or smaller in size than normal RBC. There are Hobel-Jolly bodies. They seen only after post splenectomy, as normally these pluck out or destroyed by the splenic macrophages, but after post splenectomy Hobel-Jolly body can be seen. Hobel-Jolly bodies are the dark nuclear remnants or DNA remnants seen in the cases of post splenectomy patient severe hemolytic anemia, megaloblastic anemia. MCHC is characteristically increased in the hereditary spherocytosis due to relative cellular dehydration. MCV can be normal or low. Red cell distribution width is increased. Confirmatory test for hereditary spherocytosis is EMA binding test, eosin 5 millimide binding test. This is the gold standard test, which is flow cytometry based for hereditary spherocytosis. Osmotic fragility is increased in hereditary spherocytes as the spherocytes are less flexible and lies at the higher saline concentration. Direct Coombs test is negative, and this is very crucial to differentiate hereditary spherocytosis from the autoimmune hemolytic anemia. Now on the treatment part of hereditary spherocytosis, treatment of choice is splenectomy, usually deferred until after the age of 6 years to reduce the chances of sepsis. Preoperative vaccination against the encapsulated organism like Streptococcus pneumoniae, H. influenzae and Neisseria meningitidis is advised. Post-splenectomy smears Hobble Jolly body, as we have discussed, and target cells. Folic acid supplementation to combat megaloblastic anemia. So this is all about the hereditary spherocytosis. The important thing is the defect in the RBC membrane is skeletal proteins like ankyrin, band3, spectrin and protein 4.2. So ultimately result into the RBC membrane instability. As cell ages, the RBC membrane loss and assume the size of spherocyte, which is geometrically efficient for volume to surface ratio. Thank you.